Good afternoon to everyone. We welcome you to the session on the postgraduate course for hepatocellular carcinoma, the second session for this course. So we'll start with the first session. The first session is to be given by Professor David Madoff. Professor David is a professor of radiology, medicine, oncology, and surgery oncology. He is also the vice chair for clinical research section, chief of the interventional radiology, and principal investigator interventional oncology of research lab in the Department of Radiology and Biomedical Imaging of Yale School of Medicine to give us a talk on the role of interventional oncology in the management of hepatocellular carcinoma. May we welcome Professor David Madoff. Professor?
Hey, thank you. Does this start? Thanks. Thanks for the introduction. It's great to be here in Kyoto. What I'm going to talk about is a specialty called interventional oncology and what its role is in management of liver cancer. Interventional radiology is a subspecialty that utilizes minimally invasive image-guided procedures to diagnose and treat patients with various forms of cancer. The benefits of primary interventional oncology therapy are that it leads to immediate tumoricidal effects, is minimally invasive, therefore it is cost and time efficacy or effectiveness, and has minimal side effects, which often helps with quality of life. And the goal here is really to try to make interventional oncology the fourth pillar of cancer care. Interventional oncology therapies are incorporated into multiple NCCN guidelines. I'm actually on the kidney cancer panel, and we're now actually valued participants in numerous tumor boards and PIs on clinical trials. So this is just a lot of different types of procedures that we offer, ranging from image-guided biopsy, primary tumor therapy, central venous access, palliative care, and oncologic complication management. So when looking at what we do for patients with HCC, I looked really at the goals of therapy. We look at whether it's curative, whether we can convert patients from unresectable to resectable, and then look at palliation. And this all depends on tumor histology, number and location of tumors within the liver, the extent of the patient's underlying liver disease, and the presence or absence of extrahepatic disease. To avoid confusion, what I wanted to discuss today is the various types of therapies that we do. It's really imperative to understand the definitions. When you go to tumor boards, sometimes it's all confused. Sometimes people think that microwave ablation is radiofrequency ablation. Sometimes people call TACE bland embolization, vice versa. It's all mixed bag. So the problem is that these lead to major implications for accurate medical record keeping, patient care, and even billing. So in the last session, you heard all about the BCLC. This is what we use in the US. One thing that we didn't really discuss in the last session was what's called stage migration, where you can actually move from stage to stage based on whether or not the patient is really appropriate for that type of therapy. But the bottom line is that the goal really in patients with early stage and up is to do transplantation or resection, with ablation being reserved for those with very early stage or early stage disease. And in fact, when we look at patients at tumor board, patients with 2 centimeters tumors or less are never offered surgery anymore. So it's something that was a very major paradigm shift. In terms of TACE or intra-arterial therapies, you can see that it's for intermediate stage, which is B, as well as for patients that are not able to get resection, transplant, or even ablation if the tumors are in difficult locations or they're not really good surgical candidates. And for the first time, the BCLC actually added radioembolization for single tumors less than or equal to 8 centimeters. And then we're going to hear a talk, at least later, on the use of systemic therapy for advanced stages. Although, as you'll see later, interventional oncology techniques still will have a role in trying to get patients better outcomes. So what is percutaneous ablation? Well, the goal is to eradicate all viable malignant cells and spare normal surrounding tissues. We treat tumors with unfavorable locations or patterns of distribution for resection or have multiple comorbidities. It's mostly often used in the setting of low volume disease, and as you'll see, it's now considered the first line curative treatment or as a bridge to transplant, and typically it's done as an outpatient and can be repeated. We can see that there's multiple types of ablation. They're very different in their mechanism of action. However, if you look at a lot of the Kaplan-Meier curves, they actually look pretty similar. In terms of the rationale for transarterial therapy, we're able to take advantage of the liver's dual blood supply. Most liver tumors receive blood supply largely from the hepatic artery, and we know that HCC, especially those patients that have HBV, are highly vascular. So we're able to selectively and locally deliver intra-arterial therapeutics to the patient's tumor bed. And by doing so, we can minimize systemic complications and toxicities while treating the tumor. So here we see a patient that has just a basic case of microwave ablation, 2-centimeter HCC in segment 7, who was awaiting transplantation. And you can see the small tumor on the MRI to the left, simple ablation. The one thing I just wanted to point out is that relative to RFA, there's very little heat sink effect. So the ablation really is more effective, as well as preserving the veins, as you can see right here. I also wanted to just briefly mention irreversible electroporation, where instead of using heat, this is a non-thermal technology where you actually change or alter the ionic potentials between the cell membranes, and you kill the cells that way. The thing is, though, that you need to have these needles parallel. As you can see this right here, this is a diamond. You have a diamond shape, so there's very little. You need to have a parallel so that the electrical field across the tumors are good. And in this particular case, you can see that there's a tumor that's abutting the portal vein and the biliary tree. So this is a good case for irreversible electroporation. Now, when you compare percutaneous ablation versus surgery for HCC, you can see that now there is very similar, if not improved, overall and recurrence-free survival. And this is especially true in the setting of central tumors. And in fact, when you look at the complication rate for the group with the resection is much higher. So we can see now that using percutaneous ablation, we have improved efficacy and safety versus resection, such that ablation is now really considered the first-line therapy. And this was just a survival and quality of life study that was published in the British Journal of Surgery. Here we see that there was no difference in overall and disease-free survival between ablation and surgery. However, when you look at the FACT quality of life score, there's a very big difference. So this just goes to show that you really should try to use percutaneous approaches when possible. One thing I did want to discuss, and it's not very big in this country or in Asia, but it is very big in the United States, is Y90 or radioembolization. And there's a thought that we can possibly replace ablation with what's called a radiation segmentectomy. So what this is selectively delivers high dose radiation to the target tumor and adjacent hepatic parenchyma within 2 segments. The goal is to give a very high dose to the tumor while minimizing radiation injury to the rest of the liver. And you can see here an amazing result actually with a tumor here in segment 7, dose of radiation directed to the tumor, and at 1 month follow-up, the tumor is completely dead. Now, this was a study that was performed at Mount Sinai in New York called RAZOR, which was a single-center, single-arm study of adults with a solitary HCC less than 3 centimeters with unfavorable location for ablation. So here we can see that at least they found that they got complete response rates in nearly all the patients, and most of them were actually sustained overall responses. So you can see that 90% of the patients got sustained overall response with very low adverse events. So they really believe that radiation segmentectomy is an efficacious and safe way in patients with unresectable BCLC 0 or A HCC that are considered suboptimal locations for ablation, and it should be further investigated. A way to convert patients from unresectable to resectable is a procedure called portal vein embolization. I've been doing this since the year 2000 when I used to work at MD Anderson in Houston. What this procedure does is redirect blood flow to the fetal liver remnant or FLR, and by doing so, we can initiate hypertrophy of the non-embolized segments. By doing so, we can reduce the overall number of complications that patients get, and ultimately increase the number of potential surgical candidates who have what we call marginal anticipated future liver remnant volumes. The goal here is really to achieve similar, not necessarily better, survival rates to surgical patients not requiring PVE. So this is a case of a 56-year-old man with cirrhosis and a 10-centimeter HCC with Hep B and C. The patient had a very small future liver remnant, so the patient was considered a candidate for portal vein embolization. We do it here, ipsilateral right PVE with particles and coils, and you can see that there's complete diversion of flow away from the right liver towards the left liver. We get tremendous growth of the left liver from 33 to 51%. And this is what the liver looks like intraprocedurally, where you get very, very dilated or obtuse margins of the liver remnant and a very dusky appearance of the part that was, in fact, embolized. So this patient underwent a right hepatectomy with an uneventful hospital course, but did develop a recurrence at 5 years, but then at that time underwent a successful transplant. Now, there's been only one prospective clinical trial showing the benefits of PVE. And this was because those physicians that believe that PVE works would never randomize their patient to not having PVE. But you can see here, those that had PVE versus those that didn't, that PVE actually significantly improves postoperative course. And this was a study that we did down at MD Anderson, where you see all the patients that died actually did not undergo PVE after resection of their HCC. And then if we look at the 5-year survival, they're very similar. What I wanted to just highlight here is that those patients that would not have gotten the surgery due to not having PVE would have probably undergone TACE and we had maybe a 3-year survival of maybe 20 to 30%. So you can see that just by doing a PVE, getting a patient to resection actually helps the patient tremendously. More recently, there's been a lot of interest in what's called sequential arterial and portal embolization. The rationale here is that you get the capacity for liver regeneration after PVE or resection may be impaired due to the cirrhosis. Most HCCs are hypervascular. There are arterial portal shunts that are often found in cirrhotic livers and HCC tumors. And also, once you embolize the portal vein, you actually get arterialization of the liver, which then stimulates tumor growth. And by doing this combination therapy, you get improved hypertrophy and survival, both overall survival and disease-free survival, than compared with PVE alone. And then there's another procedure called radiation lobectomy, which is very different than radiation segmentectomy. So this is where you just embolize with radiation the entire right lobe of the liver. So the idea here is that you really control the tumor while you're seeing the tumor biology. Now, the problem is that it's a much slower hypertrophy than you would normally see with PVE, and we don't know right now the kinetic growth dynamics. So it's very hard to know whether or not the patient should actually have surgery after they get Y90. And in some cases, if the patient does well, you would just leave the Y90, let it do its thing, and not take the patient to surgery. So what exactly is meant by TACE? We heard a lot about TACE in the last session. There's many technical aspects of this procedure that vary widely among both published data and clinicians. And in fact, if you were to go to my own hospital, you would see that multiple faculty would actually do TACE differently. Now, TACE is often utilized as an umbrella term to refer to 3 distinct but all related procedures, whether it be bland embolization, conventional TACE, or drug-eluting BTACE, but they all follow the same pattern of being done in a very similar fashion. Now, bland embolization is embolization without chemotherapy. You're only using the embolic agent. The goal here is to completely occlude the tumor-feeding vessels, which then causes ischemia and then ultimately necrosis. Of course, this usually leads to hypoxia, which may activate several genes such as VEGF. So you really need to get patients under control in terms of their tumor growth. These patients usually have 50 micron particles that are used for embolization or even smaller. And this was just a successful case of a patient that underwent bland embolization as a bridge to transplant. You see here this 4.8 centimeter HCC in segment 8. And here after bland embolization, the tumor is completely necrotic and the patient was transplanted 3 months after the embolization. And this just shows that the data, similar to other kinds of embolization, show that it does work. Conventional TACE is an infusion of a mixture of chemotherapeutic agents with iodized oil followed by the embolization with particles. This was actually developed in Japan by Professor Yamada back in 1977. And again, there's a lot of ways that this can be done, but The fact is that it's now recommended by a lot of different societies, such as the Society of Interventional Radiology, as the first-line treatment for inoperable HCC in patients with well-preserved liver function. Now, as I said, in the U.S., Y90 has really blossomed, and I don't know if it's really any other place. I mean, in fact, 80%, from what I understand, of the world is still doing conventional or some kind of TACE. This just shows that it's non-standardized, that there's multiple different embolic agents, multiple different drugs, but the oil is very important. And the situation here is that it's not cleared by the cancer cells, and the oil acts as both a drug carrier and is tumor-seeking, as well as being an embolic agent. And what happens is that the oil goes through the arterioles into the portal venules, and then ultimately occludes doubly. So you get an arterial and portal occlusion, and then you take the particles, put it behind it, and that actually stops the forward flow of the blood. And this is just a case of a tumor that's treated with conventional TACE. You can see that the oil with the iodine in it actually shows very well, and this was a successful TACE. Now, these are just some of the landmark studies that we know. This one was from the Barcelona group in a very highly selected group of patients with HCC and HCV compared to best supportive care. And then this was one from Professor Lowe in Asia that was largely, again, highly selective patients with the majority of HBV. So these are all like classic studies from early 2000s. And what I wanted to show here is that it used to be where if you start getting uptake into the portal vein, you actually stop. But you can see that when you get more portal vein uptake, you actually get much better results. So here you see a case where a patient has a segment 4.8 centimeter HCC. We do the embolization, or you see the angiogram with the hypervascular mass. You can then see in this area here that you have portal vein here, so you definitely have a good occlusion. This is the immediate cone beam CT right there. And then this is pre and 1 month post. You can see that there's definitely excellent necrosis of the tumor. Here we see that there's long-term adverse events that can occur with conventional TACE because at some point the lipiodol does separate out from the chemotherapy. So at that point, drug-eluting beads were something that was developed. The idea here is that you can get a much more predictable retention and gradual washout, and hopefully reduce systemic toxicity. And this is just a case. Don't want to spend too much time on this, but you can see that it worked. And this was just one study that showed that there was very effective utilization of drug-eluting beads. And in fact, idarubicin is a good agent. In terms of radioembolization, again, this is not really done a lot in Asia, although I think that it is going to increase. It is a beta emitter that we do transarterially, and there's two different products. I just want to make sure that we all think that they're not the same. So each product is very, very different. One is TheraSphere, one is Sursphere. They have different properties. One is made out of glass, the other one's made out of resin. The one that's made out of glass actually has a 3 times the specific gravity. So when you're infusing it into the artery, sometimes you'll see on a scan that all the particles fall into a much more dependent location. So whatever the mapping shows may not actually result in what the actual treatment shows. So this was just a case of a 92-year-old female who had a ruptured HCC, and you can see that there's very good uptake of the material into the tumor. And 4 years later, you can barely see it, a complete response. And this patient went from 92 and died at 98 of other causes. The one toxicity that I'd like to talk about, because they're all rare, is just fatigue. Because you are radiating the liver, there is a chance that the patients can get really, really decompensating fatigue. And then this was just one study from Northwestern where they're really big believers in this. So they did the first 1,000 patients showing the benefit of Y90, mostly in BCLC-A and BCLC-C, with mostly Child's Pugh A and Child's Pugh B. And you can see that they're stratified in terms of survival based on their child's Pew status. But now at Northwestern, for example, they use Y90 solely for transarterial therapy. And then this was just a case or study highlighting the fact that portal vein tumor thrombus is very effectively treated with Y90. And then how do you decide between radioembolization or TACE? Well, there was systematic reviews and meta-analysis that basically show that TACE does have more pain associated with it, but TARE has more fatigue associated with it. So it's really hard to say which one's better. Now, if you ask certain groups, they believe, for example, like at Northwestern, that Y90 is the only way to go, but I have my doubts. Lastly, just want to focus on what was talked about at the last speaker, talking about immunotherapy. Local regional therapy can shape tumor immunity by altering the composition of the tumor microenvironment. These procedures do cause necrosis of tumor cells, and then they release tumor neoantigens, and then ultimately they recruit and activate dendritic cells into the microenvironment. So you can basically try to transform immunosuppressive microenvironments that are not conducive to checkpoint inhibitor therapy and turn them into immunosupportive settings, making systemic therapies much more effective. Here we see how complex the tumor microenvironment is. There's the various local regional therapies do have different mechanisms. Some are immunostimulatory, some are immunosuppressive. However, when clinical trials are being discussed, how you should do them, it's really important to know so you don't have confounding variables, what type of therapy you're going to use, because the companies really don't know. And when they offer these studies, unless they talk to one of us as interventional radiology, they may, like I said, may have confounding variables. This is just a laundry list of the different types of immune stimulation and immune suppression. I'm not going to go into all of them because it would take me like 10 minutes. But you already heard in the last speaker about Emerald-1, which was the first global phase 3 trial to show improved clinical outcomes for systemic therapy in combination with TACE, which I thought was really amazing. And this was just the fact that the RMB, which is here, shows that TACE plus Durva plus Bev actually has a significant improvement in progression-free survival versus TACE alone. So I think this is really important and is going to lead to a long list of new studies where various local regional therapies are going to be combined with immunotherapy. And this is something that is coming down the pike. So in conclusion, I hope to have shown that local regional therapies do play an important role in the management of HCC. They often provide survival benefit, local tumor control, and improved quality of life. And in some cases, we never used like the word curative TACE. Now, I know in Asia, curative TACE is something that is talked about all the time, but I never tell a patient that's having anything to do with TACE that they're cured. And also can enable bridging or downstaging of patients eligible for transplant or surgery. As I showed, there's various ablative and transarterial therapies. They all have different mechanisms of action. But the one thing that we didn't discuss is the technology. TACE is not TACE, as I kind of mentioned. There is a lot of technology out there now that's going to help with choosing which patients will be better for various therapies, whether it be AI or augmented reality. AI will help determine radiomic features possibly and clinical characteristics, which may help determine whether or not a patient should even have immunotherapy combined with TACE. And then there's a whole future of combinations that we're going to hear about, I'm sure, later, whether it be immuno-oncology or other combinations of various interventional therapies. So with that, I'll stop there and thank you for your attention.
Thank you very much, Professor. I think he has given us a long list of interventional oncology procedures that can help us in our practice. May I know if there are any questions on the floor? Yes, please identify yourself, sir.
Dr. Wong from Hong Kong. I'm a surgeon. I would like to know what is the experience of a hypovascular HCC? What is the choice for an inoperable HCC, hypovascular? Conventional hypo.
Well, it depends, right? So there's so I'm a TACE person. I think I've kind of alluded to that. I know that in a lot of hypovascular cases, there's a couple of things you can do, and I've been a very big advocate of balloon occlusion. So balloon occlusion technically is supposed to be a low pressure embolization, right? In terms of the fact that the tumors don't have the same arterioles and vasoconstriction that normal liver has. So when you put up the balloon, you get all this flow directed to the tumor, which you don't typically get. Okay, so you can do a couple of things. One is that you can do a high pressure, get the material through there, and ultimately get it into the portal, like I said, the arterial portal vein. The other thing that I do is I guess, a segmentectomy-like approach, right? So even if the tumor itself doesn't take up the LAPI at all, or the chemoembolic agent or whatever you're going to use, the surrounding area is all full of it, and the tumor will just starve. So if you have in a situation where, now it depends on the tumor, right? I mean, it's like kind of hard, it's hard to generalize these things, but I've done cases and I've published reports on doing, like, for example, balloon occlusion, chemoembolic segmentectomy, where, like, for example, pancreatic cancer, totally, usually avascular or very minimally vascular. And we got excellent treatment by putting up a balloon and forcing the material there.
So you would still suggest a conventional TAC with some special techniques? How about the Y90?
Well, I was going to say Y90 is another option. You can, it's the same thing.
You won't go directly to systemic therapy for those?
Well, again, it's like I don't know the case. I mean, it's one, you're asking me a question about a hypovascular tumor, but there's a lot more to it than that, right? So it's hard to know.
Are there any other questions? Oh, let me throw one. You gave us a lot of strategy for small tumors. May I know what is your rule of thumb to use? RFA, microwave, or any other procedures for small tumors?
Well, again, that depends on location. Now, I haven't used RFA since probably 2010, so that is not an option for me.
So most of your procedures now are microwave.
Yeah, well, they're pretty much all microwave in the liver.
Okay.
Now, we have shown that we do some IRE, very, very rare. There's actually a new device that's coming out that we're trying to obtain at my institution that doesn't require, it's similar, where it's a pulsed electrical field, but you don't need that parallel system. So you can do it like you're doing a regular ablation. But at the same time, if the tumor's in a very difficult location, you would do transarterial therapy.
Okay.
So it all depends.
Okay. Are there any other questions? Here in Asia, some of the hepatologists are doing the ablation therapy. So I guess that's why I was asking if there are different indications on the interventional radiology side versus the hepatologist. So I guess there's not much difference.
Well, I think the indication should be the same.
Yes, I guess
regardless
so.
of who's
Yeah.
doing it.
Yeah, right. As long as the expertise is there.
Yes, exactly.
So thank you, Professor. Thank you for a very nice lecture. So we move on to our next session. Our next lecturer is Professor Takumu Fukumoto. He is Fukumoto. I'm sorry, sir. He is a professor of the Department of Surgery in the Division of Hepatobiliary Pancreatic Surgery of Kobe University Graduate School of Medicine. He will give us a talk on the current status of multidisciplinary treatment for advanced hepatocellular carcinoma in Kobe University. Professor, thank you.
Ladies and gentlemen, Chairman, first of all, I would like to express a sincere gratitude to the President, Professor Shino, and organizing committees. Today, I would like to talk about the current status of multidisciplinary treatment for advanced hepatocellular carcinoma in Kobe University. I'm surgeon, therefore my role is highlighted the surgery for the treatment of HCC. I have no COI. In general, multidisciplinary treatment for malignant small will consist of radiology, surgery, and chemotherapy. However, HCC treatment will conventionally consist of surgery, radiofrequency elevation, and TACE because the effectiveness of radiology and systemic chemotherapy to date were limited. However, several new therapeutic options have become available, and of these, lenvatinib and atezolizumab and bevacizumab are key drugs, which have potential to change the treatment algorithm of HCC. Current status of HCC treatment in Japan, in addition to the development of systemic chemotherapy, particle radiotherapy can be used for the novel local treatment since 2022. In the area of the surgery treatment, national health insurance coverage for robotic surgery was approved in the same years. Along with the development of a novel chemotherapy and radiotherapy represented by particle therapy, treatment for HCC have entered into the new era with the treatment options. The prognosis of systemic chemotherapy improved from the era of sorafenib. The MST of atezolizumab in BRAVE 150 was 19 months, which was significantly better than that of sorafenib with 10 months. Based on these outcomes, revised BCL classification clearly indicates the detailed regimen of systemic chemotherapy for BCLC stage B and C, whereas the indication for hepatectomy is still limited to a part of stage 0 and A's. The protocol was revised again in 2022, adding a clinical decision-making to the flowchart, but without significant change to the actual treatment selections. Many hospitals have treated HCC based on BCLC. Through the accumulation of the case, gradually, it became clear that chemotherapy for advanced hepatocarcinoma, like HCC with PVTT, shows less favorable outcomes. The MST of the patient with VP4 treatment by sorafenib, lenvatinib, and atezolizumab were only 4 months and 6.6 and 76 months, respectively. This slide shows the background of today's lectures. Advancement in systemic chemotherapy, amino checkpoint inhibitor of atezol and bevacizumab and tolilumab and nirulimab became the first-line treatment for unresectable HCC. Lenvatinib also shows the favorable treatment outcomes. Chemotherapy for HCC with PVT is less effective in prolonged prognosis. Advancement in radiotherapies. Particle radiotherapy has become a novel treatment options. Multidisciplinary approach. Hepatectomy play a significant role for advanced HCC. Current controversy is still exists about the best treatment strategies. We herein report our treatment experience for advanced hepatocarcinoma as basis of making a multidisciplinary treatment plans. For this purpose, we will show you 4 studies about HCC treatment performed in Kobe universities. Agenda of the present study are listed here. Study 1, hepatectomy versus sorafenib for a patient with VP2 or VP3-4 PVTT. Flowchart of this study 1 regarding HCC patient with PVTT. 142 patients underwent hepatectomy of Kobe University and 85 patients received the sorafenib during the period were subjected. Of these, 50 patients were VP2 PVTT who underwent hepatectomy and 90 patients who received sorafenib were compared. Furthermore, 36 patients in each for VP3-4 PVTT underwent hepatectomy and sorafenib were compared. This slide shows the patient characteristics of VP2 PVTT. There were the same statistical difference between our hepatectomy groups and the sorafenib groups. The MST was significantly better than for patient with hepatectomy than that of sorafenib. This slide shows the patient characteristics of the all VP34 PVTT patient. There were also some statistical difference between the hepatectomy groups and the sorafenib groups. The MST was significantly better for patient with hepatectomy than that with the sorafenib. Patient characteristics of VP3 for PVTT after a matched pair analysis. There was no statistical difference between the hepatectomy and the sorafenib groups. The MST was significantly better for patients with hepatectomy than that with the sorafenib, even after propensity matched analysis. Study 2, a treatment outcome of the systemic chemotherapies. The MST lenvatinib was 16.3 months, and the objective response rate of the modified RECIST and RECIST were 33.1% and 13.9% respectively. The MST of atezolizumab was 20.2 months, and the objective response rate of modified RECIST and RECIST were 37.7 and 29.5 respectively. The MST of dilutore was 8.9 months, and the objective response rate of modified RECIST and RECIST was 10.4 and 10.4 respectively. Drug-free achievement, we emphasize this recently, emphasize the drug-free achievement after systemic chemotherapy of 286 patients who received lenvatinib, atezolizumab, and dilutore. 20 patients once achieved the drug freeze. The breakdown of the treatment was as follows. Conversion hepatectomy performed in only one cases during that 286 patients after atezolizumab in our hospitals. Study 3, treatment outcome, reductive hepatectomy, extrahepatic metastasis, and multibilobar metastasis. This slide shows the patient characteristics of all 32 patients. Of 32 patients, 14 had N1M0, 16 had N0M1, and the remaining 2 had N1M1. This slide shows the tumor characteristics of 32 patients. 90 patients had intrahepatic maximum tumor size less than 100 millimeter, and 30 patients had tumor less than 100 millimeter. 30 patients had intrahepatic tumor number less than 2, and 90 had tumor number more than 3. About half of the patients had oncologic emergent situations such as VP34 or VP3s. The MST of all 32 patients was 11.8 months, and the 3 years overall survival was 17.9%. Prognostic analysis according to the patient characteristics. Any factor did not affect the survival regarding the patient characteristics. Meanwhile, regarding tumor characteristics, intrahepatic tumor size more than 100 millimeter and intrahepatic tumor number more than 3 were the significant factors which affected worse survival. Accordingly, for patients who stratify the both factors with intrahepatic tumor number less than 2 and the intrahepatic maximum tumor size less than 100 millimeter, the MST was as high as 39 months. This slide shows a summary 1. Aggressive surgical approach may be justified for HCC patient with extrahepatic metastasis with an intrahepatic tumor number less or equal to and the intrahepatic maximum tumor size less than 100 millimeters. Outcome reductive hepatectomy for intrahepatic multiple bilateral metastasis. A patient characteristic of 107 patients, about 70 of patients had an intrahepatic tumor number more than 6. The most MST of all patients was 18 months and 3-year overall survivors 22.8%. Prognostic analysis for OS showing that the serum albumin less than 2.9 and the total bilirubin more than 0.9 were the significant factor affect the poor survivors. Accordingly, a predictive score using the serum albumin and the total bilirubin was established, and the risk score was stratified. Survival was clearly stratified according to the predictive score, with the MST of patient with score 0 was 20 months. Regarding the reductive hepatectomy for intrahepatic multiple metastasis, score 0 was a good candidate, and score 2 was basically contraindications. Study 4, HCC with IVCT, hepatectomy versus particle radiotherapies. A comparison of demographic data after matched selection of the two groups. Patients were well matched for both patient and tumor factors. Survival rate of the 19 patients according to the proton radiotherapy and hepatectomy, although not statistically significant, survival of proton radiotherapy groups tend to be better than that of the liver resection groups. This is a survival curve in the sub-analysis of the stage 3B. In this patient population, survival proton radiotherapy group is significantly better than hepatectomy group, and the MST of proton radiotherapy group is as long as 24.6 months. This is a typical case of IVCT treated by particle radiotherapy. HCC with IVCT regressed with time and achieved clear clinical CR, and the patient was alive for 4.5 years. Now we move to discussions. In the IMBRAVE 150 trial, the MST of atezolizumab was 92 months, which was significantly better than sorafenib. However, according to the subgroup analysis of IMBRAVE 150's trial, the MST patient with high risk status including BP4, small occupation more than 50%, and the bile duct invasion was only 7.6 months. In the present study, the MST of the reductive hepatectomy for distance metastasis stratified to criteria was 39 months, and intrabilateral metastasis with score 0 was 20 months. From the literature review, the death cause of the advanced HCC was mainly due to the aggregation of the intrahepatic tumors. Considering that the main death cause of the advanced HCC was due to the aggregation of intrahepatic tumor, there can be a validity with controlling intrahepatic tumor with reductive hepatectomy for certain patient populations. Conversion surgery is an upcoming concept for advanced HCC recently. The concept of conversion surgery was quite standardized for colorectal liver cancer and pancreatic cancers. However, considering the low ORR of chemotherapy for HCC compared to that of the colorectal liver cancers, and considering that the recurrence pattern of HCC was overwhelmingly occurred at the locally, than systemically, we have to take a caution approach for introducing conversion concept for HCCs. Conclusions: hepatectomy, even with a reductive intent, is acceptable for advanced HCC, such as with PVTT. Multiple intrahepatic and distant metastases are when stratifying the criteria. Under the current response rate of chemotherapy, caution must be required for the concept of compound hepatectomies. Along with the appearance of new chemotherapeutic agent and particular therapies, further study regarding the multidisciplinary approach be required. Thank you for your attention.
Indeed, very interesting, Professor. Are there any other questions on the floor? What is your most common complication in reductive surgery?
Surgery? Bile leakage.
Uh,
Bile leakage. Bile leak.
Okay,
Mortality, in general, in Japan, the mortality rate after liver resection lower than 1%.
but this is not the main cause of mortality.
Yes.
It is the main cause of mortality. So in your patients, Professor, how many of your patients, what is your percentage of mortality as far as reductive surgery is concerned?
A little bit high. The case series is a little bit old.
Yes.
I think it's 3%.
3%.
That
Ah,
means.
Okay, are there any other questions? So I think we'd like to thank Professor. I think it's a very interesting work for advanced cancer. Thank you.
Thank you very much.
Our next speaker is Professor Kazumi Ueshima. He is an associate professor of the Department of Gastroenterology and Hepatology of Kindle University of the Faculty of Medicine in Japan. Professor Yoshima will give a talk on optimizing the treatment sequence in chemotherapy of hepatocellular carcinoma. Professor.
Thank you for introducing me. It's honor to me to make my presentation here. And today I would like to talk about optimizing the treatment sequences in the chemotherapy of hepatocellular carcinoma. This is my disclosure of COI. So this slide shows the changes in systemic chemotherapy for hepatocellular carcinoma in Japan. And since the launch of sorafenib in 2009, worldwide, there was only one drug available. Since 2017, new drugs have been approved one after another. Currently, 8 regimens of 9 drugs are available, including 2 combined immunotherapy regimens. This is the latest version of BCLC staging and treatment strategy, and the first line treatment is atezolizumab and bevacizumab, and durvalumab plus tremelimumab. And if not feasible for immunotherapy, sorafenib or lenvatinib is selected. But no clear indication is provided as to which regimen to choose. And this is Japanese clinical practice guideline, the latest version. It was created based on evidence. The first choice is combined immunotherapy, and if indicated, atezolizumab, bevacizumab plus bevacizumab or durvalumab plus tremelimumab is selected. If combination immunotherapy is not indicated, so sorafenib, lenvatinib, and durvalumab monotherapy are selected. But this algorithm does not provide a detailed selection method. Which regimen do you choose first in the first-line treatment? In immunotherapy, objective response rate and progression-free survival a surrogate endpoint for overall survival. It has been reported that the higher the ORR, the longer the OS, and the longer the PFS, the longer the OS. This indicates that selecting a regimen with good ORR or PFS can prolong OS. This is a comparison of the efficacy and safety of atezolizumab plus bevacizumab and durvalumab and tremelimumab. Atezolizumab plus bevacizumab has a better objective response rate and lower progressive disease rate than durvalumab plus tremelimumab. In addition, atezolizumab bevacizumab has a low incidence of IRAEs requiring steroids, and it's considered to be highly safe. Professor Kudo, he's my boss, says prioritized requirement for first-line systemic therapy regimen is wide and broad benefit and less toxic, and atezolizumab plus bevacizumab satisfies this condition. Professor Robert suggests first considering the suitability of bevacizumab and choosing atezolizumab plus bevacizumab if bevacizumab is suitable, and choosing durvalumab plus tremelimumab if it is bevacizumab is not suitable. Professor Finn also suggests as same, first considering the suitability of bevacizumab. So regarding efficacy and safety, the first choice of the first-line treatment is atezolizumab plus bevacizumab. If bevacizumab is unsuitable due to complications such as esophageal varices or poor cardiac function, durvalumab plus tremelimumab is selected. If immunotherapy is unsuitable, lenvatinib is the first choice because of its high response rate. Next, which regimen do you choose for second-line treatment? I will show you a 2x2 contingency table consisting of atezolizumab, bevacizumab, and refractoriness and intolerant. In the case of bevacizumab intolerant, durvalumab plus tremelimumab is selected as same reasons previously I mentioned. In the case of bevacizumab refractoriness, this is the role of VEGF and VEGF receptor. Bevacizumab is an anti-VEGF-A antibody. It works by blocking the ligand VEGF-A, and by blocking VEGF-A, the signal to VEGFR2 inhibit. The serum concentration of VEGF-A decreased markedly after treatment of anti-VEGF-A. So on the other hand, VEGF-C and VEGF-D increased alternatively. So alternatively, increased VEGF-C or VEGF-D binds to VEGFR2 and angiogenesis is reactivated. VEGF-A ligand blockade induces and increases VEGF-C or VEGF-D to VEGF receptor interaction. This is one of the mechanisms of resistance of bevacizumab. An increase of VEGF-C also activates VEGF receptor 3. So activation of the VEGF-C, VEGF receptor 3 pathway induces tumor immune escape, which worsens the tumor microenvironment and results in tumor progression. Therefore, VEGF receptor blockade stops the signals or VEGF-C or VEGF-D. The VEGF receptor inhibitor, the TKI or ramucirumab, can overcome the resistance of bevacizumab. Anti-VEGF treatment induces an alternative pathway of FGF through a hypoxia induced by VEGF blockade. In the chronic VEGF inhibit model, FGFR2 is consistently activated. Continued inhibition of VEGF alone activates alternative pathways by FGF signals and worsens the tumor microenvironment. So FGF receptor inhibitors may be effective for patients who are unresponsive to VEGF and VEGF receptor inhibitors. Only lenvatinib blocks both VEGF receptor and FGF receptor in the approved drug for HCC. Lenvatinib may be effective in the cases of bevacizumab refractoriness. In the case of bevacizumab refractoriness, lenvatinib should be selected. So next, let us consider in the case of atezolizumab refractoriness. This is a molecular classification of HCC based upon immune status. It is well known that Wnt beta-catenin mutations shows resistance to immune checkpoint inhibitor monotherapy. Lenvatinib may be effective regardless of gene mutations related to CTNNB1 and the Wnt beta-catenin pathway. It is reported that beta-catenin expression and high FGF receptor 4 expression are correlated. Beta-catenin is activated by FGF19 receptor 4 signal pathway. FGF4 blockade may inhibit beta-catenin signal and result in inhibiting the tumor progression. Several reports have shown that lenvatinib is effective for HCC patients with FGFR positive cases. Lenvatinib may be effective in the cases of atezolizumab refractoriness. In the case of atezolizumab refractoriness, lenvatinib should be selected. Finally, consider in the case of atezolizumab intolerant. Atezolizumab intolerant is easy to understand, only immune-related adverse event. Immune-related adverse event, IRA, is a disease that causes autoimmunity due to overreaction of the immune system activated by immune checkpoint inhibitors. So if IRA occurs by atezolizumab, any immunotherapy is unsuitable and TKI should be selected. There are many reports that the biomarkers related to progressive disease on atezolizumab plus bevacizumab. Lenvatinib is sometimes effective in such a state, and lenvatinib sometimes overcome this state. So in summary, it is reasonable to choose lenvatinib after progression on atezolizumab plus bevacizumab. Then, which regimen do you choose after progression on durvalumab plus tremelimumab? We have reported that lenvatinib demonstrated considerable anti-tumor activity in patients with unresectable HCC who are unresponsive to PD-1, PD-L1 checkpoint blockade. This is why, due to the temporary should combined effect of ICI remaining in the body. This is our case. After progression on durvalumab, lenvatinib was very effective. After administration of lenvatinib 1 month later, the tumor changed into a hypovascular tumor with necrosis. After progression of durvalumab plus tremelimumab, lenvatinib is very effective. So lenvatinib should be selected for second-line therapy, either from the theoretical background or from the efficacy perspective. So the take-home message, the first-line treatment is atezolizumab plus bevacizumab. So if bevacizumab is unsuitable, durvalumab plus tremelimumab is selected. If immunotherapy is unsuitable, lenvatinib is the first choice. Lenvatinib is recommended as a second-line treatment for patients who are refractory or intolerant to immunotherapy. Thank you for your attention.
Thank you very much, Professor. Are there any questions from the floor? I was just interested, if you say that lenvatinib is would work with ATE and BEV refractory, why can we not start with lenvatinib as a first line? Why do you want? I was just thinking along your trend of thought. If there are ATE and BEV that are refractory, and lenvatinib would work, is there any reason for us to do lenvatinib as a first line rather than as a second line drug?
Lenvatinib is first line?
Yes, because is there an indication where lenvatinib can be used as a first line?
So your second, lenvatinib is is not first line or first choice. So first line of first choice is atezolizumab plus bevacizumab.
Okay. Are there any other questions on the floor? So thank you, Professor. Thank you very much.
Thank you very much.
Our next speaker is Professor Masufumi Ikeda. He is a chief of the Hepatobiliary and Pancreatic Oncology of the National Cancer Center Hospital, East Japan. And his topic will be on postgraduate program of systemic therapy for liver cancer. Thank you, sir.
Thank you for your kind introduction. I'm Masafumi Ikeda, National Cancer Center Hospital, East Japan. So first of all, I would like to thank President Sina for inviting me to this APASL meeting. And it's my great honor to have an opportunity to make a presentation today. Title of my talk is Systemic Therapy for HCC. This is my disclosure. This is a category of the regimen for HCC. The regimen was divided into molecular targeted agent for VEGF inhibition and immunocheckpoint inhibitor. VEGF inhibitor is a bevacizumab, sorafenib, lenvatinib, regorafenib, ramucirumab, and cabozantinib. While the immunocheckpoint inhibitor is a tremelimumab, CTLA-4, durvalumab, PD-L1, and atezolizumab, PD-L1. This slide shows the available systemic therapy in Japan. Sorafenib, lenvatinib, atezolizumab plus bevacizumab, durvalumab plus tremelimumab, and durvalumab monotherapy were reimbursed already in Japan for first line or any line treatment for advanced HCC. Regorafenib, ramucirumab, or FP400 or over, and cabozantinib were reimbursed in Japan for second line or later line treatment, advanced HCC. At the present, a total of the 8 regimens are available in Japan. This is a history of the development of systemic therapy, first line advanced HCC. Sorafenib demonstrated a positive result by SHARP trial in 2007 and Asian Pacific trial in 2008. Based on these results, sorafenib has been established as a first systemic therapy for advanced HCC. After the introduction of the sorafenib, a lot of the clinical trial, phase 3 trial was conducted comparing the sorafenib. However, almost all negative results. In 2017, lenvatinib has been reported to be non-inferiority to sorafenib by REFLECT trial. In 2019, atezolizumab plus bevacizumab, atezolizumab demonstrated a superiority over sorafenib by IMbrave 150. And in 2022, durvalumab plus tremelimumab demonstrated a superior on overall survival over sorafenib by Himalaya trial. Thus, the era of the multikinase inhibitor changed to the era of the immunotherapy. This is a comparison of the atezolizumab versus durvalumab. Both regimen was reported to be superior to the sorafenib. However, overall survival, progression-free survival, objective response rate, disease control rate were slightly better in atezolizumab plus bevacizumab. However, this is a cross comparison between trials, not directly head-to-head comparison. So I'm not sure which is better. This is a JSH Japan Society of Hepatology HCC guideline 2021 updated 2023, which treatment is recommended as a first-line systemic therapy for unresectable advanced HCC. Recommendation is atezolizumab plus bevacizumab or tremelimumab plus durvalumab is recommended as a first-line treatment for unresectable advanced HCC. Recommendation is a strong level, and evidence level is also A. Sorafenib or lenvatinib is recommended if this treatment is not suitable due to the comorbidities such as autoimmune diseases. Recommendation is also strong and evidence level is A. Thus, atezolizumab plus bevacizumab or durvalumab is listed in parallel in guideline. From now on, I will introduce some promising trial of Morpheus trial. This is a tiragolumab. This is a randomized phase 2 trial of tiragolumab plus atezolizumab versus atezolizumab. Unresectable HCC patients with no prior systemic therapy were randomly assigned to a tiragolumab plus atezolizumab arm and atezolizumab arm. Primary endpoint was investigator-assessed over objective response rate by RECIST 1.1. This is a result of the objective response rate and progression-free survival. Objective response rate was 42.5% in tiragolumab arm and 11.1% in atezolizumab arm. And median progression-free survival was 11.1 months in tiragolumab arm and 4.2 months in atezolizumab plus bevacizumab arm. Hazard ratio was 0.42. So combining tiragolumab with atezolizumab resulted in improved anti-tumor response compared with atezolizumab. So, phase 3 trial of tiragolumab plus atezolizumab versus placebo plus atezolizumab in Brave 152 trial was ongoing now. This slide shows the ongoing clinical trial in first-line setting. Checkmate 9DW, in Brave 152, Impact, Relativity, and Gemini trial. A lot of clinical trials are underway. Among them, Checkmate 90W was press released to be a positive result last week. Ipilimumab plus nivolumab meets the primary endpoint of overall survival for the first-line treatment of advanced HCC. I move to the second-line systemic therapy for advanced HCC. After the introduction of the sorafenib, a lot of agents were tried as compared to the placebo. Among them, 3 trials become positive: regorafenib, cabozantinib, and ramucirumab. This is a treatment algorithm of systemic therapy by Japanese Clinical Practice Guideline, updated 2023, after the atezolizumab or durvalumab. Second-line treatment was selected in the all regimen, not selected in the first line. So after the atezolizumab, sorafenib, lenva, rego, ram, cabo, tremeb, durva monotherapy can be selected as a second line or later line treatment. This slide shows the ongoing clinical trial in second line setting. In Brave 251, Review 1 for global trial, and select 400 succeed trial for domestic trial. At the present, the development of the treatment after failure of immunocheckpoint inhibitor are underway. Which regimen do you select it in the second line or later line? This is our prospective observational study of systemic therapy for HCC, so-called PRISM trial. To clarify the real-world evidence, real-world data, so we conducted this PRISM trial. Unresectable HCC patients who will receive the first-line systemic therapy were registered in this trial, and we get the efficacy result and safety result in first line, second line, third line, or fourth line. The aim of this study, real-world data is collected in Japan. Real-world evidence is established. The enrollment period was 5 years. Rounded sample size was 2,000 from the 42 hospitals. This is enrollment status. Until the March 2024, over 1,400 patients already registered in this trial. So this is a Japanese big database of systemic therapy for HCC. So near future, many results will be presented from the PRISM trial. I move to the TACE plus systemic therapy for intermediate stage HCC. So intermediate stage HCC, 2 trials was become positive, Tactics trial and Emerald 1. Today, I introduce the Emerald 1 trial. This is a study design of Emerald 1. Intermediate stage HCC patient with no prior TACE and systemic therapy were randomly assigned to a TACE plus durva, followed by durva plus placebo. and TACE plus Durva, followed by Durva plus Bev, and TACE plus placebo. Primary endpoint was progression-free survival by RECIST 1.1 central review. This is a result of progression-free survival and time to progression of TACE plus Durva plus Bev versus TACE plus placebo. As you can see, TACE plus Durva plus Bev was significantly better result in progression-free survival and time to progression. This is a forest plot of progression-free survival. Except the small number of the patient cohort, TACE plus Durva plus Bev shows a favorable trend. This is a progression-free survival and time to progression of TACE plus Durva arm versus TACE plus placebo arm. Unfortunately, there is no significant difference in progression-free survival and time to progression between TACE plus Durva and TACE plus placebo. So intermediate stage HCC, so VEGF inhibition is maybe essential. This slide shows an ongoing clinical trial in intermediate stage HCC. Emerald 3, LEAP 012, Checkmate 74W, TACE 3, Tarantase. Various clinical trials of combined immunotherapy were underway. So finally, I will talk about adjuvant systemic therapy for early stage HCC. Positive result was 2 trials, IMbrave 050 and Sinchilimab trial. This is a study design of the IMbrave 050. Patient with HCC with high risk recurrence after curative treatment of resection or RFA were randomly allocated to atezolizumab plus bevacizumab arm and or active surveillance arm. Primary endpoint was progression-free survival by independent review facility. And secondary endpoint was overall survival and so on. This is a treatment outcome of recurrence-free survival by independent review facility and overall survival. Left side figure shows a recurrence-free survival. As you can see, so the adjuvant atezobev demonstrated a significantly better recurrence-free survival. Hazard ratio was 0.72. P-value was 0.012. However, no significant difference between two arms in overall survival. Hazard ratio was 1.42. Another trial is a randomized phase 2 trial of adjuvant Sinchilimab versus active surveillance. The study subject was HCC with macrovascular invasion after curative resection. The enrolled patients were allocated to a Sinchilimab arm and active surveillance arm. The primary endpoint was relapse-free survival by intentional to treat population. This is a result of the recurrence-free survival and overall survival. Adjuvant Sinchilimab demonstrated a significantly better recurrence-free survival as compared to the active surveillance. Hazard ratio was 0.534. P-value was 0.02. And also overall survival, the trend toward better overall survival. Hazard ratio was 0.505. So in a early stage HCC, VEGF inhibition is not essential. So this, based on this result, so immune checkpoint inhibitor monotherapy is also effective for early stage HCC, adjuvant setting. This slide shows an ongoing clinical trial for early stage HCC. Checkmate 9DX, Keynote 937, Emerald 2. The development of adjuvant immunocheckpoint inhibitor after curative treatment are currently underway. In conclusion of my talk, systemic therapy is now available for any stage of diseases. While previously, local therapy used to be a main treatment strategy for HCC. Systemic therapy in combination with local therapy is being actively tried at present. Systemic therapy is currently promising topic of the development of novel treatment for HCC. Thank you for your kind attention.
Thank you, Professor Ikeda. Are there any questions from the floor? What about the use, Professor, of, yes? Oh, there is online, I'm sorry. Who has the question? I think they were, was there a question on the online? I couldn't see. There's none online. None. Okay. So what about, Professor, on the use of, again, I was going to ask lenvatinib as an adjuvant therapy for early HCC, because you used immunotherapy. So what about lenvatinib and sorafenib? I think that's already an established one, right?
Yes, thank you very much. So thank you for your good question. So sorafenib, adjuvant sorafenib is already reported by the STOMP trial.
Yes.
The trial is a negative,
Yes.
quite similar overall survival and recurrence-free survival. So sorafenib, so multi-kinase inhibitors may be negative. So lenvatinib is also, so in advanced stage HCC, lenvatinib is non-inferiority to sorafenib. So very similar to
So-
the results. So maybe we think so the not effective for the adjuvant setting. However, the immunotherapy is maybe a good candidate for the adjuvant setting because two trial is a good result demonstrated. So one is immune checkpoint inhibitor monotherapy and one is atezobev. So IO-based regimen is, I think, a good candidate for the adjuvant setting.
Okay. So how long do you give your adjuvant immunotherapy for early HCC?
So not yet. So because of the evidence is not established, just only recurrence-free survival. So IMbrave 050 method is a recurrence-free survival. However, the overall survival is quite similar. So that means that in my idea, so overall survival is similar equal no needed to adjuvant settings, so adjuvant therapy. So if the overall survival is quite so some superior trend in the atezobev arm, so we will switch to the adjuvant therapy to use to the atezobev. However, now the present result is we don't use to the adjuvant atezobev.
Yes, and in your tiraglumab and plus ate plus bev study for intermediate HCC seems interesting as compared to, do you have any data as comparing it with DOR plus bev?
Oh, so thank you for a good question. So the Emerald 1 trial demonstrated a positive result in terms of the progression-free survival only. So overall survival is not yet reported in the Emerald 1 trial. So we will waiting for the final result of the Emerald 1 in overall survival.
Yes, okay. So I guess we'll wrap up the session. Thank you, Professor Ikeda.
Thank you very much.
I think this was a very interesting session. Let's give a warm applause to our first speaker. They have actually given us an out-of-the-box strategy for advanced HCC, where the frontiers of new drugs will come in and indications might change in time. I think it was started by Professor Madoff on the interventional oncology and armamentarium of the different drugs of different interventional oncology procedures and local regional therapies that can help us in our treatment for advanced HCC. Professor Fukumoto actually gave us a role of reductive surgery and its role probably in advanced HCC. Professor Ushima actually gave us on the role of lenvatinib as a second line therapy for patients who have either a refractory for ATM plus BEV, and of course, our last speaker who gave us a systemic therapy for adjuvant HCC, for early HCC. I guess this is where the new frontiers will come in the next few years. So thank you, and we'd like to invite you tomorrow to our opening ceremonies for Apostle 2024. Thank you.
Thank you very much to the lecturers and moderators. This concludes the session in Room 4. Thank you for attending today.
Sir, can Oh, yes, yes, yes. Yes, yes.
So you are center.
Okay.